So I'll go to background. Where I'll go? Background rooms.
Yeah. I think the 3 dots that is there on the right hand side, there you will be able to find that option.
Just to make everybody aware, the live stream which was there on YouTube has started. So without much ado, we can start. There are 128 people in the waiting room, so I'm admitting all of them. So we go as per the plan. Madhukari ma'am, we start with you to request you to start the moderation. And
yeah, but it has not yet, my background is not getting changed.
Ma'am, can you blur it at least? People have not yet joined. It's just we are here.
There is an option when you do a right click, it says blur my background. If you can choose on that.
If you can just click on that, ma'am.
No, it's not coming.
Next to mute, there are 3 buttons.
Just click on the 3 buttons on the right hand side on the top. On your window.
Yeah.
Just click on that.
Done.
It says blur my background, or
can I blur the background?
No, you can't.
Can I blur ma'am's background? No, ma'am, that's okay, ma'am. People are waiting. They will leave, ma'am. We'll start. I'm switching off my video and handing over to you. Over to you, Madhukari, ma'am. All the best.
You can stop this screen share.
Ma'am, stop screen share.
Yeah,
I'll stop the screen
share. This is my
share.
presentation from. Yeah. You can stop now when Madhukari speaks.
Yeah.
Yeah, that's fine. Yes.
Good afternoon and namaste, everyone. Those who have joined in the Zoom and those who have joined in the YouTube. Good afternoon, everyone, for taking out your time and joining here in the webinar. We have been, Apollo is conducting this webinar series of webinar from 1st of this month till 10th of this month. And then every day there are from 3 to 4, there are such programs are going on. And I would request all of you to register yourself in the same link and then join, so that you can attend all these sessions and you can have a lot of value additions in your practices. At the same time, I would like to tell you that we will be having on 13th and 14th at Delhi, we'll be having International Patient Safety Conference organized by Apollo. And today's conference is on patient safety, today's webinar, and we have 3 eminent speakers with us. My first speaker is Captain Ajita Nair, and she is, I have 3 speakers, Captain Ajita, Juliet, and Dr. Sneha Vaidya. Captain Ajita is the Managing Director, Helbis Healthcare Private Limited, Kochi. Currently, she is working as Managing Director over there, but she has an enriched experience over so many years, over last almost 30 years. Her previous prestigious positions held in different organizations as a Chief Nursing Officer in Avitis Institute of Medical Sciences, Palkat, Kerala. Chief Nursing Officer, Astra Medicity, Kochi, as Chief Nursing Officer at Military Hospital, Kozhikode. Chief Nursing Officer, Fortis Memorial Research Institute, Gurgaon. Director Nursing, Ruby Hall Clinic, Pune, and various positions in Military Nursing Services. She also has accolades like Management Development Program in 2021, MSc Nursing from Christian Medical College, Vellore in 1998, and BSc Nursing from Armed Forces Medical College, Pune, 1992. She is an entrepreneur herself, and she has varieties experience as NABH Principal Assessor, faculty and past committee member entrepreneur since 2021. She has vast experience in hospital operations management as consultant. Her core competence is in implementation of cost-effective, sustainable, process-dependent operations management solutions for hospitals and change management. So she also has different experience like commissioning hospitals, recovery of ailing hospitals, training and development framework of all categories of hospital employees. So she has a vast experience. I would request Captain Ajita to start with your topic. Today, her topic is on. She is going to speak on staffing for patient safety, the nursing leadership role. So nurses play a major role in patient safety, and that is, and of course, the staffing is very, very important. If there is no adequate staff, the safety cannot be assured and ensured. So I think this is the burning topic which actually all nursing homes and all hospitals are really facing every day in and out. I think Captain Ajita will be able to enlighten all of us on this burning topic. So I would request Captain Ajita to start with your presentation, please.
Thank you. Very good afternoon to everybody. And thank you, the organizers, for inviting me to talk on probably the most vital issue, survival issue rather, facing all hospitals, especially in the private sector. And this is about nurse staffing. So let me go over to my presentation. The nurse staffing is such a burning issue of late. It has ever been an issue for past many decades rather, but today it has achieved a notorious position in the issues faced by hospitals than ever before. So I'll just touch upon in 15 minutes. I do not know how much justice I can do to the topic, but then I will just share my views on the same. So I would be talking about staffing for patient safety, the nursing leadership role. So as I said, it's the most challenging aspect of departmental operations, nursing departmental operations in any private sector hospital. Government sector too have problems, but not as much as, or it's very different. Their challenges are pretty different from the private sector, because private sector does not necessarily offer, sort of job security per se as perceived by people, and hence, people don't stay on with the private sector at all. Now, the problem is not that. The problem post-COVID era is totally different from what we had been facing for decades together. So it literally, the capabilities what we have gathered over decades of running the hospital has proved not enough to manage it adequately and appropriately without compromising patient safety. So all the hospitals across the country had been facing this, rather the world over. This problem is being faced, that enough nurses are not there, or there is a wide competency lag or gap versus what is required. But the very different factor what makes India different from when we compare it with the developed world is that we do not have much of a plan, or it has not affected us so much, I feel, at times. Except the nursing heads are running healthcare sector, but the rest of the people, yeah, it started affecting the doctors, definitely, yes. But management, not yet, I feel. And public at large and government, not at all. So what does it make different from what it was 2 years ago? Is it is most dynamic. Who will stay, who will go, we don't know today. Tomorrow 10 people, 20 people may come with resignation. And it is consistent. Over past, say, about a year or so, it had been so consistent, owing to the wide gap of, positions created in the UK and many developed countries, not to mention the Middle East. Rather, people now prefer to go to a English-speaking developed country rather than going to the Middle East. So, the situation on ground is changing every day, and we need to really break our head to find ways or dousing the fire every day. So we do not get even time to think about what happens after a year or so. Same time. So what has been learned is that no solution is forever. I mean, we have tried different methods over a period of time, but nothing of that sort works forever. So we have to be at it finding solutions on a day-to-day basis. And the changing socioeconomic equations, which affects all of us, rather is one of the cause for this. And this is different in different states. So you find this problem mostly, or the most hospitals which face this problem is those traditional care-like nurses dependent organizations, I feel, because other state people do not have as much of a craze to go to, outside the country. Exception maybe a little bit of Punjab and maybe Rajasthan a little bit. And this has affected, otherwise the prominence of Malayali nurses in private sector was a given thing, but now that is all changing. So wiser people have moved away from recruiting Malayali nurses and started recruiting people from the local area so that they will not go. So we will have to change the way we deal with the issue, I feel, and not really asking people to stay on for no reasons. And balancing patient safety and cost has become a big issue now, because we are doing all these firefighting at a pretty serious cost, which is patient safety. So what is the role of nursing leadership is that you have to see that enough staff is there in each unit who are competent to take care of the patient in adequate number, and easier said than done. Even you are doing things which you have never done in life before. Like, say, for example, putting a 3-month-old novice staff to liver transplant ICU. I've never done that in life. But yes, my cardiothoracic ICUs, liver transplant ICUs all have people who have not even completed an year of service. And even to the operating rooms. And to my surprise, I find that, they are there for the 4th month. They started scrubbing for CABG all by themselves. So not that they are bad. They are not bad. They are catching them faster. But on the 7th month, they come with their resignation. So all that effort, what you put into, the moment it started getting some results, they are gone. And the cycle repeats. And maintain a safe nurse-patient ratio all the time, 24/7, 365 days. While meeting everybody's requirements, while the outgoing nurses or your wastage is much higher. And skill mix, again, that is a thing of the past, though in accreditation standards it's given as a responsibility that skill mix should be ensured. What skill mix when you have the entire workforce is less than 1 year old? So we are actually compromising the patient safety to a larger extent, I must say. And maintaining your KPIs. People don't want any medication error, people don't want any faults. Yeah, nobody is going to compromise or agreeing to look at this issue even. So maintaining this fine balance is the biggest challenge every nurse head is facing. Nevertheless, yes, it's a tightrope walk, balancing act. You don't know when you fall, and the number of tossing balls in your hand keep increasing. And a moment of lack of attention will topple the entire system. So it has become, the nursing department has become very, very vulnerable, I feel, of late, where you're just crossing your fingers and waiting for a calamity to happen, actually speaking. And trends of staff turnover, it is over 60 to 70% annually in all major hospitals, or a quaternary level hospital for sure. Tertiary care, yes. And we don't have much idea of what happens in primary care and secondary care, actually, because our attention never goes there when we sit in a larger setup, actually. And well, but the management wants higher return, higher income every day, bed strength has to increase, patient turnover has to increase. So nothing of this sort is going to stop, right? So only thing what is being compromised is we are not getting staff, and whoever is there are getting more pressurized. And as a result, nurses are leaving the profession. And patient acuity levels also in a hospital keep increasing, right? So it was not 10 years ago the same thing. Today we have so many patients on ECMO at a time. And many of them are on various other gadgets like this, which requires much higher costs to sustain their life. And obviously, it requires more competent staff and more attention from nurses. And clinician and top management requirements is not in tandem with what is available anyways. And of course, nobody is willing to compromise, or no one will come down from their position. But well, there is a limit. There is a threshold for a system to bear all these things. And I'm afraid that this threshold is reaching very fast. I do want my management that, the day is not far where you will have to curtail admissions, because there is a limit. And so also clinicians, it has already started affecting clinicians, where, they are feeling the pinch of not having a trained nurse around. And of course, they undergo all that stages of NABDA, denial, bargaining, that now it is, I think, bargaining stage. And well, acceptance probably will take a little more time. And acceptance is finding out alternatives. We can't really say that nurse is not there, so stop taking patients, right? And staff profile and availability in the market, well, it's the nurses who know the job are not available in the market. How do I recruit? Only one criteria. Do you have a valid license? There my question ends. Because there is no point in what I was doing, say 5 years back or 3 years back, where I see 20 people and choose 1 or 2 out of it. Gone are those days. Today, the only criteria for taking staff into a quaternary care hospital, where we have all type of cases going on, is just a registration. It's deadly situation, I would say. Where does the buck stops? The answer is obvious. It stops at the director of nursing desk. If you are chief of nursing, you had it. It is no one else is answerable, I feel. No one is asking any question. Look at this. I thought I will not bog you down with tables, but then I could not help but sharing this one. This is my hospital's experience-wise distribution. I calculate this for every month. I got this October 1, so nothing significant in October. You see, in my hospital, there are 950 staff on that day, and 496, 52% of them have less than 6 months experience. So this many 500 staff have gone. That is why they have come in. I mean, isn't it so dangerous? Isn't it so detrimental to patient safety? And there is, you can't make a staff nurse who is so named a novice nurse to make an expert in a month's time, 2 months' time. Everyone is in a hurry. And very unfortunate that everybody wears the same uniform. The nurses have only one face, the uniform. They are identified with the uniform. It doesn't say how many years of service or how much you know about a thing. It doesn't say so. It doesn't reflect on competency. So everyone has the same expectation from every nurse. I mean, nurses are under so much pressure because of this. And no choices. We do not have any choice, unfortunately. So we do have this issue of, say, how to train them. And all of those novice nurses who come. So, you have 100 nurses going experienced, and 100 of them we will have to replace, right? So out of them, 90 are novice nurses. Now, these novice nurses have earned their degree by studying, looking at a screen. They do not have skill looking at somebody's eyes and talking. So from there you have to start. And skills can't be acquired overnight. I feel like, screaming this sentence, skills can't be acquired overnight. I have to ask everyone that, hey, you became like this after so many years of toiling, and you expect a nurse within no time to become an expert in what she does. And retaining, well, no one wants to stay. I've been to our College of Nursing the other day. They have 100 new students, BSc Nursing first year students. So there is CNO's address there. And I've just asked them as a prelude, how many of you want to go abroad after your studies? All of them, 100 of them want to go abroad. Can you blame them? You can't blame them. Why should they stay here? If they feel that they have better future elsewhere, they'll go. So now let's talk about solutions in another couple of minutes. Well, I don't have any magic solution to offer, unfortunately. Global issue needs global solutions. So if few nursing heads sit together, the solution will not come. I'm very sure of this. And nobody has invited us to talk about this, first of all. No one, because no one feels, or still people feels that they can, train some 10th class pass few people and, they can run the nursing department. That is what I feel people think about. So the most pressing issue what healthcare faces today is not nurse staffing according to the owners of healthcare or the who's who of healthcare. That's a little bit disturbing, of course. And failure to get enough attention to this issue is a problem, yes. And of course, all of us work on our own ways of managing this issue, and working in silos we will exhaust our energy, and that is the only outcome going to be. Instead, if we come together along with the management, think of solutions, and I'm sure we will be able to find some solutions. And also the apathy from government, from policymakers as to how much issue is healthcare issue actually. Still doubt, we just heard the budget. I still doubt how much issue is healthcare issue in this country. So what can we do? Yes, well, all said and done, what can we do when we sit on the hot chair? Close monitoring of the situation. Yes, if you allow your number to go down, it will be so very difficult to build it up. And yeah, you have to put people through training. I mean, I'm sure you have heard of it all the time, but it is most important than ever before that people don't know how a thermometer looks or how to give an injection. I mean, absolute blank. So we have to start from ABCD. We have to recreate the entire syllabus, what is required for us in a month's time. So I do have a month's training now and another month of hand holding on the floors. So in 2 months' time, they start taking patients themselves. And yes, the nursing head should have a sense of, I mean, you have to have the pulse all the time felt of staff utilization, the rate of wastage, ratios, etc., etc. So if you know your numbers, probably you are able to, at least appraise the management about what is actually ground situation. And maybe something which works is you be part of the solution than complaining. I feel you show that you can manage the situation without much harm to the patient, and then you win some arguments at least. And yes, public initiative, something which we have to make it a debate point where I'm sure nobody is coming to the hospital to face a crisis of not having enough people to handle them who know the job. I'm sure public is not prepared for that. So we got to probably, got out of our boundaries and, reach to other people who can find, at least suggest solutions. And I'm sure putting our brain together, probably we may be able to find some solution. Government accountability, how to hold them more accountable for healthcare of this country is a question which is never answered. And health should be as important as food, accommodation, and education for the government, actually. But the allocations in budget doesn't say that. How much we care is evident from our actions or lack of actions. That's what I want to say as a last comment, that do we care enough? If we care enough, we will be able to find solutions. Thank you.
Thank you, Ajita, for your wonderful presentation. It motivates us to think that how important it is to start all the nursing heads to start thinking that, yes, from the point of view that acuity of patient care, in terms that, yes, if we have say a general ward where we have surgical patients and we have a general ward where we have neurology patients, of course, where depending on the acuity of the patient, what sort of manpower that we'll have to allocate. That's very, very important. And at the same time, you said very correctly that we have to appraise our management. We have to keep on appraising the HR head and the management that what is the scenario going on, where we are foreseeing some problem happening. And also, if we can think of having some contingency plan in terms of manpower hiring on manpower planning, like we should be following a trend. We should be following that what sort of attrition can happen, and accordingly what should be my like it cannot be one time I hire say 200 nurses and then I sit quietly. It has to be a continuous process of hiring, and there like we can plan accordingly so that we don't run short of the nursing manpower all of a sudden for any exodus or any like government uptake or anything. So these are very, very important points that you have highlighted. Thank you very much for highlighting very burning topic, and I think it makes us think that what should be the next step for all nursing heads and the nurses, because we cannot stop the career of nurses to be going abroad or anything of that sort. Very correct. I would now come to my next speaker, Ms. Juliet Varghese. She is currently Director of Nursing, Apollo Main Hospital, Chennai. Juliet is an acclaimed healthcare leader, and she is currently heading Apollo Chennai Main. And Apollo Chennai Main is the flagship hospital in Apollo Group. She has over 23 years of experience as head of nursing in different renowned hospitals in Mumbai, like Jupiter Hospital, Thane, and many other hospitals. She has always been a topper. She always projects herself to be a topper. There's no doubt about it. And she completed her BSc, MSc nursing from LT College, SNDT University. Miss Juliet has partnered with some nursing team of multiple research projects. She had been having a keen interest for Critical Care Nursing Council across Apollo. All Apollo hospitals nursing council, Critical Care Nursing Council is headed by her, and we can see every week on week lots of activities that she keeps on doing for making nurses learn about critical care nursing. She is always looking for means to increase patient safety in all aspects, and she is the key pioneer. She plays a key role all the time, and she's passionate about professional leading several nurses into change management and transformations. Without much ado, I would request Juliet to start with her presentation. And she has a topic which is again very essential, that is patient safety in critical care units. The nurse's role is very, very important for all of us to understand. Juliet, the session is for you now, open.
Thank you, Madhukari, and a very good afternoon and namaste to all of you all from Apollo Main Hospital, Chennai. I want to thank you at the outset, the organizers of the IPSC, for this wonderful conference, which deals with patient safety, and also Usha ma'am, who is our Director Nursing for the group, for nominating my name to speak on this very, very critical topic. So as far as we are concerned, we are going to put up the PPT, and we're going to be talking about 10 to 15 minutes about the whole issue of patient safety in critical care units and the nurse's role in it. I'm sure I'm audible to all. So to err is human. That's a common adage, a common proverb that is being told. Anybody makes a mistake, the best way to get out of the mistake is to say to err is human. Now, in the same way, there was a report by the same name or the same proverb, to err is human, in the year 1999. And it was released by the Institute of Medicine, and it showed 98,000 deaths per year occurred. And I'm sure that none of us can say to err was human, because 98,000 deaths occurred because of clinical and medical negligences. And that is how the patient safety movement came into play. Patient safety is a very, very critical topic for not only for every hospital, but for every nursing leader. As Ajita ma'am has said, the buck stops with us. And I'm sure that all of us today here, every nursing leader and every nurse, whether she has experience of 30 or 40 years, or whether it's a new joinee of yesterday, all of us are directly or indirectly concerned with patient safety. Now, what exactly is patient safety? Patient safety is a healthcare discipline. It's a healthcare discipline. It's not an option. It's not an opinion. It's not something that I want to do it today and not do it tomorrow. It's a discipline, and it emerged with the evolving complexity in healthcare systems and the resulting rise in errors in healthcare facilities. So the more the errors came up in healthcare facilities, the more the negligences were there, they thought about having some sort of a discipline as far as patient safety is concerned. So patient safety basically came out of advocating for patients to be safe in the hospitals that they come to, or in the practices that are adopted onto the patient. So we have dealt with this patient safety culture on Saturday. There was a beautiful session by Dr. Sahana, Dr. Yatish, all of them, and it was very, very well presented as to how we can develop a patient safety culture. A culture is something that goes, it is an in thing, the ethos of that institution. And it's basically a set of attitudes and opinions, perceptions shared by the employees in the field of patient safety. That means it is something that is breathing in and out in an organization. And how good to have all our organizations to be a safe area or a safe zone for patients. And when I look at here, the definition, we look at employees. So it is not only nurses. Although nurses are considered to be the most influential member in the healthcare team, they are the most important person because they spend the maximum time with patients, but they are not the only ones involved with patient safety. You will agree with me fully that the moment the patient enters the hospital, right from the gate of the hospital till the patient leaves the hospital, his safety is in our hands. And right from maybe the security guard at the entrance to the topmost consultant in the hospital are responsible for patient safety. Each one of us, no one is excluded from patient safety. Even the joint patient, the JCIA makes it mandatory that patient safety be adhered to at all times in the hospital. And they had the national patient safety goals formulated, and now we have the international patient safety goals in order to reduce patient errors. Now, coming to the topic, why is patient safety so important in critical care units? You can see on the screen, 5.2 million errors happen in India alone. There is another statistics which says in 2006, there was 205 ICUs were studied very closely for patient-related issues, medical errors, negligences, and they found 38.6 errors which were there per 100 critical care days. So that's a very, very big number. 5.2 million medical errors happen in India in India alone every year. So when you're talking of 5.2 million, that means 5.2 million times the medical personnel or the hospital has done something wrong for the patient, and the patient has been unsafe in that hospital. So it shows the vulnerability of every patient admitted to the hospital, either to an error or danger to life itself. Now, why do we talk about these patients in this way? You know, we critical care safety, basically because our patients are very ill. They require continuous monitoring. The care of patients is very, very complex. You know that most of the hospitals right now have ICUs which are having state-of-the-art equipment, the highest of technology, and so many things are there. So we know that patient and the diseases that we get are very, very complex. So the patients are very complex. Life and death situations are to be made very, very quickly. And many individuals are involved in the care of patient. So you have a whole lot of people coming in, complex situations, decisions that are there to be taken. So in all of those areas, we see that the patient safety gets compromised at some point or the other. And it is us, as I'm talking to a group of nurses, that we are the ones who are who own the patient. We are the ones who are responsible to make sure that our patients are safe. As We are the stakeholders. Now, when we talk about patient safety, see, many times when most of us seniors who are on recruiting panels, when we talk about, we ask a question to a nurse, what will you do about patient safety? How can you keep your patients safe? And the first answer that they give is raise the side rails. So patient safety is not only about prevention of a fall, although that is a very important part of patient safety. It's not the only aspect. Here, I'm just sharing a few of the aspects of patient safety in a critical care unit. A nurse would be responsible to ensure safety in all of these parameters to keep her patient safe in the shift that she is in. And for a nursing leader to observe that at all times, at all shifts, 24/7, 366 days of the year, that this patient is going to be safe in all these areas. So medical safety is one area. Surgical safety, electrical safety, the lab safety, infection control, blood and blood product safety, and I would also put medication safety over here, the equipment safety, and the environmental safety. I think these are very, very common and these are terminologies which we use very regularly. So nothing is new to any one of you. So when we talk about patient safety, you know, we talk about the IPSGs. Everybody knows about the 6 IPSGs, but just to refresh your memory over here, improving the first goal is to improve the accuracy of patient identification. How often do we call our patients by bed numbers or by a consultant name? Or we also call our patients by a diagnosis. How often? Just check what you have done. Maybe you are working today, and how have you addressed a patient? Give me the file of so-and-so bed number. Can you give me the file of the patient admitted under so-and-so patient doctor? Can you give me the file, can you give me the file of that patient who has been admitted with fever yesterday? So this is very common. So let us identify our patients correctly with the full name of the patient, not only the name, because you may have 2 Juliets on the same floor or 2 Juliets in the same ward or ICU. So let's have a full name identification, and also with the ID number. There may be a UHID or any of that sort. Please make sure that the IDs are correct. Improve the effectiveness of communication amongst patients, amongst the caregivers. So in this, it's not only a handoff which takes place at the handing over of the patient in a shift, but wherever the patient goes from the ICU to maybe the OT, from the ICU to a imaging center, wherever, a proper handoff to be given. And I'm sure we use the proper ISBAR with identification, situation, background, assessment, and recommendation. Without the proper ISBAR, there is no point of giving a halfway handoff to the receiving staff. Improving the high alert medication safety. Medications in your hospital are categorized under high alert for specific reasons. Either they, when you are giving it, you have to be careful. They will cause critical side effects. There has to be a monitoring that comes in. There are so many reasons why that drug is put under a high alert. And when we see that high alert medications are given, we have to double check. When you ask nurses, what is a high alert policy? It's only double sign. Double sign comes much later. We have to double check about the complete drug using the 6 rights, and also making sure that every aspect of that medication is checked properly, signed off. And when the patient is on a high alert medication, there is a proper monitoring schedule that is there, which has to be followed. Ensuring correct site, correct procedure, correct patient surgery and procedure. This basically is for patients in critical care who require to be taken in for an emergency surgery, maybe a craniotomy or a laparotomy, or emergency procedures that require to be conducted within the critical care setup itself. So make sure that the sign in, sign out and the timeout is carried out properly. Dr. Sneha will be giving us more information on that when she takes the next session. Then reducing the risk of healthcare associated infections. Hand washing is utter utmost priority over here, following all infection control protocols. Reducing the patient harm resulting from falls, fall prevention measures in the ICU. No patient should fall in the hospital. How much more in an ICU? That the patient should never ever have a fall. It's high negligence. So we must make sure that our patients in critical care are safe, will not fall off the beds, or if they are mobilized onto a chair, or they're being mobilized in the critical care unit, they must not fall. So making sure that there is adequate precaution for the same. And also try to involve the family members wherever you can in the prevention of patient harm. Special attention to be paid to dangerous abbreviations. Our nurses today, most of the time we are on WhatsApp using abbreviations, so many abbreviations. You see that abbreviations cascading down into doctor's notes also, into the nurses' notes. We see that happening so often. So these are dangerous practices which require to be avoided. Staff nurses have to be very vigilant on that and make sure that we do not follow abbreviations, but everything on a medical record to be written in complete in the full form, or use universal and hospital approved abbreviations. Look-alike and sound-alike medications, make sure that the medications that we use are absolutely checked. They are all coming under high alert. So please make sure that it is done. Shoma, can you please check? There is somebody on my screen, please.
Yes, ma'am.
Critical test results. These are very, very important. Please follow the readback policy. A critical value that is being informed by the lab must be taken down correctly. A proper verbal order policy should be followed. A readback policy should be followed. And make sure that the documentation is done correctly. Proper action to be taken on the same, and the documentation also to be done correctly. Make sure that whatever the critical value is, it is conveyed to the doctor, the report is shared with him, and the corrective action is also taken and documented. Clinical alarms. Nurses and the leadership have to make clinical alarms a priority. Making alarm safety a priority is one of the mandates of the JCI in the 7th edition, chapter COP, and 3.1 is a standard. So recognizing a clinical alarm and mitigating the risk of the clinical alarm will prevent patient harm. Most of the times, the nurses in the critical area have alarm fatigue. It becomes a part of the music and cacophony which is there inside the critical care unit. So even a critical actionable alarm becomes not important, or it can be considered as a false alarm. We know that there are actionable alarms. We know that there are false alarms which get generated in a critical care unit. So there are the alarms which can come because of technical issues. It can be a nuisance alarm. You have not set the alarms properly. So there is continuously alarms happening. So make sure that the alarms are set properly, and the purpose for what the alarm is set, that should get satisfied with the alarm management. It will be good for you all to study. Those who are outside Apollo, it will be good for you all to study the alarm systems inside your ICU and take the required measures on it. Remember, clinical alarms, the more technology we have, the better it is. And we have inbuilt alarms to tell us that there is a harm, there's a danger, and make sure that the patient is attended to immediately. Now, factors that improve patient safety in critical care units. There are many factors. I've just taken a few of them, and this is like a revision again. Use of monitoring technology will assist the nurse to act fast before there is a danger to the patient. So the better the technology, the faster the nurse acts rather than a manual system. Make sure that if a patient is conscious and oriented, He's able to understand his treatment. Involving the family and patient in the treatment will help reduce medical errors as they are involved in their own care, especially conscious patients and oriented patients in your high dependency unit, where they are more aware of their medication and things like that. It's always good to get them involved in their care, and medical errors will be reduced quite a lot. Promote a team atmosphere and team dynamics. Continuous skill assessment. Ajita ma'am has also spoken about this. Training is what she put. And we also talk about the same thing. Skill assessment and training of nurses to inculcate a culture of patient safety at all times. That is extremely important. We train, but inculcate that culture. They breathe in and breathe out patient safety at all times. Responding to adverse events by performing a root cause analysis and implementing targeted corrective measures, and applying evidence-based risk strategies.
Juliet, if you can please carry on, like you have hurry up a little bit.
Yeah, sure.
Because
blood safety.
Of time. Yeah.
Yeah, sure. Blood safety. We know about blood safety, the proper processes for transfusion of blood and blood products, for infection control, hand washing, and sterile techniques. Make sure that all the equipments used in the critical care unit, they are safe electrically, as well as they're hooked onto a UPS so that patient is not endangered. Fire safety, presence of water sprinklers, smoke detectors, and fire extinguishers. The lab safety, of course, with the blood and other specimens being collected, proper identification and transport, and safety for radiological procedures. New equipment, adequate training for all nurses to handle the new equipments in the department. Teamwork. Without teamwork, we cannot go ahead. And teamwork of each one of us is responsible for that. We must have a very strong leadership in the critical care, where that team leader will articulate the clear goals and make decisions effectively. We have to have debriefs after every procedure or complex patient situations, and comfort of the team members to report any incidents or ask questions if required. That's very, very important to create a just culture and a good reporting culture. Next. So barriers. What are the barriers for implementing patient safety? We say do all this, but what is the barrier? Ignorance of staff to the priority of patient safety. So if the patient is, the nurse is not oriented and a culture of patient safety is not built, this is going to be total ignorance. It's no point talking on patient safety. So build up the training on patient safety and a culture. The lack of resources. If you do not have enough of staffing, that's going to be a problem. You cannot have patient safety. So we need adequate staff and make sure that the workload is what they can manage, whether it's a 1:1 or a 1:2 justified ratios. Please make sure that we have enough of resources. Then most of the time they're resistant to change. So work with them. Always I say, whenever we have issues, don't focus on the person, but the process. We are here to focus on patient safety and let that be our desire at all times. Culture of blame. I didn't do it, she did it, he did it. That is a problem. And even punitive action. All incidences to be closed with training, sensitization, refresher training, etc. Lack of senior leadership, understanding, and involvement with patient safety issues. All of us definitely have to work at ground level so that we understand our patient problems and take appropriate action. And the culture of healthcare, workforce perception, their attitudes and behaviors of error cover-up must be changed. The more we report, the more corrective action we take. All of us are responsible for patient safety, and critical care is an area, is a zone where patient safety is very, very, very important. And we must own up to that and make sure that our patients are safe. They come here for care, and let us give them care and not errors. So thank you very, very much for this patient listening. Thank you.
Thank you, Juliet. I must say that your last slide was very, very powerful, and it was carrying a lot of messages in terms of having not to have punitive action for anything happening, because any incidences should give us a lesson to learn and then learn from the mistakes and then reduce the number of mistakes. Also, we have many other challenges in the critical care area, like we have different syringe pumps, different companies syringe pumps, different companies ventilators. So it's important that when our nurses are exposed to this type of vulnerable environment, it is important that training and equally communication is very important in terms of reducing harm to the patients. So now I would like to invite my third speaker, Dr. Sneha Vaidya. And Dr. Sneha Vaidya has got another important aspect of nurses' role in terms of in the operating room, because again, patient safety is very, very important in operating room as far as nurses' role is concerned. Dr. Sneha comes like she is a very dynamic leader, coming having immensely passionate towards delivering quality nursing care of international standards. She is having total 17 years of senior leadership experience, and she believes in learning and leading in humble field of nursing. Currently, she is working as Regional Nursing Director, Western Region, Apollo Hospital, Navi Mumbai. She takes care of Nasik, Ahmedabad, and Gandhinagar. She is instrumental in service care delivery, improving work scenarios and empowering organizations all across Mumbai, like Nanavati Hospital, Global Hospitals, and Lilavati. I would request Dr. Sneha, I welcome you to come up with again enlightening us on the patient safety towards in the operating room, which is again very, very important and versatile topic for all of us to learn from you. Thank you. Dr. Sneha, please.
No, already shared. Share के लिए मुझको
Yeah, so namaste and good evening to one and all. Thank you, Usha ma'am, for giving me this opportunity to share this very, very important role and to be in this wonderful platform where I would be talking about the patient safety in the operating room and how important it is for the nurses to play a very important role. If I have to take you back, there are many studies that are done and why the safety is very, very important in operation theatre. So two of the studies that I thought I would just like to share with you is one where an adverse events and patient safety in the theatre, where a perspective of around say 549 surgeons were taken. So where a chief medical officer had done the study. So he wanted to know regarding making surgery safer. So understanding that, it was understood that annually an estimation of almost around say 1,29,416 untoward events happened in UK. So that was one of the study that I would like to share. So how important it is and what are the adverse event and how the life can be complicated for a human being, that has been appeared in various studies across and the international platform. There was another study which cited to show about almost 15% of patients globally get affected because of the adverse surgical incidents, and almost say 7 million post-operative complications happen. So there are many studies that proves, and there are many opportunities that are created to develop and see how safer operation theatre can be for a patient. Moving forward, what should a nurse exactly do? Why it is very important to know that the nurse has to ensure the safety of the patient in the operation theatre. So it doesn't start only in the theatre, it starts right from the various parameters that are there. I would take you all across in a different perspective. One is scheduling, prerequisites, safe preparation of surgery, sign-in, intra-operative safety, timeout components, sign out, shift out, and recovery room monitoring. If we go to the different aspects of it, right from the scheduling of the correct patient with the UHID, name of the surgery, specific requirements that are required for a surgery, whether it is an instrument, equipment, implants, consumables, if any, and the duration that is required. There's a lot of communication that happens at this particular point of time. If the communication is abrupt or if the communication is incomplete, that is the first mode of where one can land into one of the major complications of a surgery, of a wrong patient that is being scheduled for a surgery. What are the prerequisites? Let us go through a prerequisite that are there. Definitely an informed, valid consent by the surgical team, a PAC that is necessary, and a consent for anesthesia, prescribed pre-op medications and specific instructions. Patient and relatives should be involved in site marking by the operating surgeon. Always we have seen a wrong site being marked or a site not being marked and a wrong site getting operated, and that landing the hospital into a lot of legal implications. Part preparations were required, a pre-op checklist where the nurse has to ensure that right from the orders that are written on the progress notes to the investigations to the prep that is required before sending the patient to the theater. Shift to the OT. While shifting to the OT, it is very, very important that, of course, you have to have a safe transport at every checkpoints, but definitely to the OT, it has to be a safe transport. While receiving the patient at the at your pre-op area, you see that you verify your patient identification, and then you have your pre-op checklist to verify whether you are there. You reconfirm the availability of the valid consent. You must have taken the consent some time ago, but you need to reconfirm the availability of the valid consent. Monitoring in the pre-op area with the vitals, and definitely a thermoregulations, which is very important because that plays a very important role during your intraoperative phase. If you go to the safe OT preparation, definitely how do you prepare a theater to have a safety? So what is it that a nurse should be very, very careful about? Maintain the sterility and surveillance of the OT. All the equipments must be checked for the function and electrical safety. While this would be done from the technical part of view or from the maintenance part of view, but there should be an oversight by the nurse to see that these functions are safe. Ensure availability of emergency medications, preparation of the trolley and the equipments, ensure availability of correct and right size implants wherever required, radiation safety adherence if required in case if you are undergoing or if there is a requirement of a laser surgery. What is sign-in? Everybody knows sign-in, but a nurse should ensure that all these components are getting managed, and it is getting managed seamlessly. So the sign-in is done before the patient is induced for anesthesia. Patient shall be involved in ascertaining the right patient, the right site of surgery, and the right procedure. Before intubation, taking a verbal confirmation with the patient, and definitely if the patient is not conscious, relative in the presence of surgical team. Safe method of patient positioning. We have always seen lots and lots of patient lands into complications if the positions have not been appropriate and correct. And definitely after that, the patient preparation where painting and draping happens. Timeout component. In the timeout component, after intubation, before the incision, a check has to be done by the entire team in the OT. So the entire surgical team should be available during the timeout procedure. So where you are again ensuring that the patient is identified correctly, it is the correct procedure, valid consent, correct site and side, correct position, and availability of necessary special equipment and implants. So you don't have to do the running up around and go in and out of the OT many times. What do you do during the intraoperative safety? This is the very, very one of the most important components where it is always missed. And this is the very easy kind of a way, or very, very a happening time when you can have the maximum mistakes, minimize the door openings, because you know that what is the airflow in and out that happens when there is a lot of traffic movement that happens in the OT. Keep accurate log of instruments. So the scrub nurse who is there has a very important role to see that the instrument count, the needles, the mops, the gauze that is there counts are being monitored properly. Monitor the patient as per the protocol. Ensure that there is, proper thermoregulation so that the temperature is maintained throughout the surgery. If you see at the general safety that we need to look in the theater, the operating safety belts has to be used for all the patients that are there in the theater, because they are with all the different kinds of positions that are there. Never disconnect or connect electrical equipments with wet or moist hands. All equipments must be continuously checked for electrical safety, while the maintenance department definitely has to ensure that the safety is maintained, so that we do not have fire, because we have witnessed several fire hazards in different places. So all these things the nurse who is there in the operation theater must ensure all the time. What is sign out? Before the closure of the surgical site, confirm the sponge count, needle count, and instrument count with the surgical team. This is done by the scrub nurse and the circulating nurse. Confirmation of the surgery, because you may have discrepancy between the pre-op and the post-op diagnosis. Definitely, this is very, very important. You check the skin integrity in view, because you use cautery, tourniquets, and prolonged positions can give rise to different kinds of skin burn or maybe redness. So one needs to definitely check the skin integrity. Confirmation from the surgeon with regard to the investigation required for specimen collected and sent properly with duly signed and filled form, and definitely a safe reversal from the anesthesia. Shift out. What is very, very important during shift out is the certain precautions that need to be taken is immediate post-op orders with regard to position, fluid management, pain management, and care of invasive lines. Very, very important. And another safety precaution that is very important and can be missed is safe sliding from the OT table to the stretcher or the bed. Safe securing of your tubes and drains, safe handling of equipments. Patient monitoring during transit is of high importance, and the handovers that are there, that are documented, has to be correctly handed over. Now, what is the recovery room monitoring? Many a times you would see there are high-end surgeries where patient would be directly shifted to the to the ICU, or there would be many of the cases where the patient would be shifted to the recovery room. So what are the important things that the nurse has to see that the continual vital monitoring happens while you maintain the temperature of the patient and the pain management? You continue with the fluid management as per the orders. If required, definitely you need to watch out for the drains and the output and the surgical wound. Definitely the family has to be communicated to see with regard to the surgical outcomes, or seeing the specimen, or with regard to what needs to be the progress and what has to be expected from this particular surgery. And definitely the Aldrich score from the anesthesia team to see that the patient can be now prepped to be transported to the ward. And in this time, definitely there is a lot of communication that happens from the nurse to the nurse of the ward or to the other department, where a safe transport has to happen to the ward. During this time, a lot of communication and documentation has to be appropriate. All that I would say that I would conclude, there is a lot for me to say, but the time being a constraint, I would say that definitely every time we need to relook and have a newer approach towards the safe surgery. And if you need to have a different kind of a culture in your operating room, one must have, or the nurse must have, a reliable collegial team work to derive your safe surgical outcomes. And this doesn't happen only with the nurse. So the nurse collaborates and coordinates with the entire team that is there in the operating room to have such safe cultures. And to end my note, I would also want to mention that there was this one study done talking about the changing operating room culture by Stephen Maggill, talking that the debriefing, they had done a study saying that the debriefing identified efficiency concerns by 26.9%. And because of this debriefing, purely 8% cases of potential adverse events were, captured. So what is very important is we need to communicate. The more we communicate, the more we are safe. If more we are safe, I'm sure that the patient who is there in our hands will definitely have more safe and will feel safe and will have better outcomes. Yeah, that's all I had to talk about the patient safety culture. Thank you so much to the entire team. Thank you, Madhukari, and thank you, Usha ma'am, for this wonderful, opportunity for me to talk something about patient safety and the nurse's role in the operation theatre.
Thank you, Dr. Sneha. We have a question for you from in the chat box. The question is, can we put sticker on the drain bag and label from OT that which one drain is negative pressure and which one is positive pressure from the OT itself? Because it is still a safety measures for patients, one of the safety measures. So
Yes,
what
we
do you
can.
feel?
Yes, definitely we
Can we
can.
start as one of the best practices, or do you feel that it is important?
Yes, of course, it is important because sometimes the way the drains. So right from the immediate post-op, I mean, when the patient is in the recovery room, there is some amount of fluid collection that already is there into the drains that are there. So definitely that creates a sense of an urgency to understand if the amount or the volume of the fluid of the drains are much more, then in that case, and if it is more than 100 ml, in that particular time, it is a race enough, an alarm that has to be alarmed to the surgeon that probably something is wrong or probably something would be right. He or she could judge at that moment. Yes, of course, we can do that.
Yeah. I think that is very important. And next question comes that how to ensure the sign-in timeout inside the OT, how it is, how we can ensure that.
Yes, the nurse who is there in the operating room has to ensure that the team is over there in the room, in the operating room, right from the surgeon to the anesthetist to the to the circulating room, circulating nurse, and to the scrub nurse. Definitely, she's over there only. They have to ensure that these components, if they need to read out all this about the patient, about the count, about the instrument count, or whether it is the site, the surgery, the team has to be in the theater room.
Very correct, which is very, very important for all of us to know and to practice on daily basis, that sign in and time out is not filling up the form. It is not a documentation. It is in true sense. It has to be filled in true sense, so that every team member understands the value of it and we can make our patient safe. On behalf of, I give my sincere thanks and gratitude to Captain Usha Madam for giving me this opportunity to moderate this very, very vibrant topic and session for that with all these three of you eminent speakers, Captain Ajita, Juliet, and Dr. Sneha. You spoke very important points and very important aspects. And last, when Dr. Sneha, you spoke about very good practice, which comes like if we every day on daily basis, if we can do a debriefing session in the OT on the incidences that happen, that can be one of the best practices, which can reduce, which can be a refreshing our remind us that yes, we can avoid mistakes, we can reduce mistakes, and that's how we can make our patients safe. So I think we have Madam has given us chance to talk on the aspect which again and again can always work as a reminder for all of us that patient safety is important, and we all nurses have got critical role in ensuring patient safety at all times in every step. It's very, very important. So I thank Ma'am Usha for the same. We have very important topic for tomorrow again, that is quality tools and techniques. There are lots of learning from the speakers that we are going to have tomorrow. So I would request audience to register yourself for tomorrow's session, and please attend from 3 to 4 tomorrow again on very important aspect of quality tools and techniques. And I thank the audience for taking out your time once again and having questions and answers by the speakers. I thank everyone, whoever has attended, and I thank my speakers and the quality team, those who have supported us. Thanks to everyone for making this event successful. Thank you so much.